Welcome to the Swift Theatre at St Patrick's Mental Health Services. I'm Dr. Sinead Lynch, and I'll be moderating tonight's WIMS FM live event in partnership with Aware on the topic of depression and mindfulness. On tonight's panel, Dr. Ursula Bates, who will deliver a presentation for us with the contributions from Professor Jim Lucey. Then following Dr. Bates's talk, we will all have a bit of a discussion on some of the talking points. But before all that, Professor Jim is going to get us started with an extract from his book, The Life Well Lived. Have a seat, Jim.
Thank you very much. I'm going to read a little passage from this book on the concept of mindfulness. Mindfulness and its concept has become one of the most helpful and hopeful developments of the modern therapeutic era. It's now so popular that it has become an established part of the everyday conversation about our mental health. So what is mindfulness? Why has it become such a buzzword? The truth is that mindfulness means many different things to many different people. At one level, mindfulness is simply a state of mind, an awareness of the present moment. At another level, mindfulness relates to a technique of meditation, typically based on a focused appreciation of our breathing. The value of meditation as a tool for mental well-being has been recognized for centuries and across many different cultures. Meditation in Buddhist, Hindu, and Christian monastic traditions is part of an ancient set of wisdom, a wisdom far older than modern mental health care acknowledges. So this mindfulness is the practice of purposefully paying attention to the moment in a non-judgmental way. Its exercise is sometimes referred to as practicing being, tuning in to each moment in an effort to remain aware from one moment to the next. Mindfulness practice includes learning how to make time for ourselves, learning to slow down, and learning to nurture calmness and self-acceptance. Mindfulness allows the body to come to rest at the moment, regardless of whatever is on our mind or how we feel. This mindful practice is said to promote awareness, empowering people to cultivate a kinder and more compassionate self. Mindfulness enables the appreciation of living in what its greatest exponent, Jon Kabat-Zinn, described as life lived in full catastrophic reality. Not surprisingly, this more mindful reality is a healthier place to be. When we are mindful, our experiences become more engaged, more opportune, and less fearful. The benefits of mindfulness are enhanced when these are combined with a cognitive behavioral therapy. The focus on mindfulness that we use comes from this combined perspective. Mindfulness and mindful meditation are core skills incorporated into many of the new therapies we use. For example, acceptance and commitment therapy, or ACT, or compassion-focused therapy, CFT. Both of these teach mindfulness as a central tool. The sense of dynamism and enhanced consciousness brought to these therapies through mindfulness is one of the most important reasons for their astonishing success. All the modern therapies have a here and now, present focus. Like the behavioral and cognitive behavioral therapies that preceded them, modern therapies concentrate on the present so that they emphasize the potential benefit of a mindful recovery. This mindfulness also allows modern holistic therapies to acknowledge a more narrative awareness of our lives. This is an awareness that focuses on acceptance of the present while simultaneously emphasizing the need for change in the future. Modern therapies aim to help men and women to reconcile the apparent contradiction in this position. For example, how can we on one hand accept reality and on the other hand commit to change it? This type of contradiction can be especially challenging when we're depressed. Nevertheless, acknowledgement of the challenge opens up a whole new set of avenue for effective therapy. Much of the scientific evidence supporting the efficacy of mindfulness has been reviewed recently. There's a wonderful review in the Lancet. You don't get better than that. It's titled Farias and Del Monte. What is mindfulness-based therapy and what is it good for? And any one of us could read that online. On the one hand, large meta-analyses. These are analyses of studies that collect data from many different sources. Look at clinical trials confirming the value of mindfulness as a treatment for depression and anxiety. On the other hand, it is difficult to be definitive or conclusive about mindfulness. We still need to learn just how mindfulness works, and we need to learn for whom it is a benefit. This is very true, but this much is also true. All modern therapies aim to be more mindful, more focused, more agile, and more flexible. In this way, they help to provide in the search for emotional peace and recovery. They are, in effect, routes to a better life, as we shall see.
Thank you, Professor Jim Lucey. That was a lovely introduction from your book, The Life Well Lived. I'm going to invite everyone now to maybe listen and be present without judgment, if you can, to Dr. Ursula Bates.
Thank you very much. It was lovely to be asked to come here tonight and talk about something that is close to my own clinical practice, but also something that I found it took a journey to get there. I started meditating when I was about 35, and all I ever did was fall asleep. So I'd sit and fall asleep and sit and fall asleep. So I went clearly not for me at that point in my life. And how I came back into it was equally in a roundabout kind of way. I went to a conference in Bangor in Wales. And I went to the conference because I kind of needed to go to a conference. So it was one of those just go to a conference days. And I found myself sitting at the back of a large graduation hall with about 300 people at this conference. And they were all sitting, breathing. And they continued to sit and breathe. And I continued to get more and more anxious and to wonder why on earth was I there, right? And I was getting more and more anxious because I actually began to get worried that they were going to start ringing bells or lighting incense or other strange things could possibly happen. But as the conference continued, John Kabat-Zinn was there himself, and he talked a lot about working in the basement of a 1960s hospital in Massachusetts in very basic conditions, going from consultant to consultant. And his one request of each consultant was, send me the patients that are not recovering. So if you've had somebody who's had a hip operation and isn't recovering the way you would expect, will you send me that person? And he designed an 8-week stress management program, and he took people from cardiac failure, from the pain clinics, people who had had operations and hadn't made good recoveries. And he gathered them in the basement of the hospital, and that's how stress management, mindfulness-based stress management began. And the one thing he did for us when he started this work in 1996, I think, is he started measuring what people were doing. So he started taking pre-measures and post-measures, which is a very basic way to begin any kind of research. But gradually, as the evidence accumulated, he realized there was something happening that was definitely going in a positive direction for people. And that was the beginnings of that work, and he wrote it out as a protocol. And the huge advantage to anything that's protocol driven is that you can hand the protocol to somebody else and they can do the same thing. So he gave us the gift of doing some measurement and writing out what he was doing and passing it on. And he very generously gave everything away. So from the very beginning, we could download his CDs and we could begin to practice. So I came back from that visit to Bangor very humbled. And I was working at the time in St. Vincent's with cancer patients, so I went and did a training course in Bangor and started running groups for cancer patients in St. Vincent's Hospital. We then ran groups for the carers, who were a group we felt were very stressed. I then moved to working with the hospice, so now I work with Harold's Cross and Black Rock. And over the years, we've designed groups for patients at the end of their lives. We run quite short groups, 30-minute groups. We've had 55 staff members now train in using mindfulness. So we run groups for the staff we run groups for the patients. And in 2015, I went back and did my doctorate and did it on using mindfulness at end of life. So is it helpful in the last year of your life to learn to breathe, to learn to meditate, to learn to be present to your reality? And that comes back to what Professor Lucey was saying, that this is about living in the full front coalface of our world. Mindfulness helps you be there to whatever is. So that's how I came at kind of doing this work. So I was very pleased to come along tonight. So we're going to obviously talk about these things. But the one thing I did want to talk a little bit about is when you put depression and mindfulness together, what is depression? And I very much like this slide because what it says is when you suffer from depression, people think you simply feel sad. You're having a blue day. Whereas what you actually feel is a very different internal experience. Depression is a very, very serious condition. You can feel very blank emotionally, you can feel a lot of deep down sadness, but some other very unpleasant states as well. A lot of self-blame, a lot of self-loathing, a lot of hopelessness, a lot of isolation. Because the big dilemma with depression is that so much is turned inwards and is locked inside yourself. So it's very important that when we're talking about depression and mindfulness, we're recognizing from the word go that depression is a very serious condition and that initially, if you're worried about yourself and worried about being depressed, it's very important to go and talk to your GP and talk to other people because the first level of treatment that's now recognized for depression is medication and therapy, right? So you wouldn't say to somebody who's feeling depressed, go to a mindfulness class. That's not the place to start. Mindfulness value is later on in your treatment. So then in terms of mindfulness, what Jim had said earlier on, when we define it, it's about paying attention in a particular way, on purpose, in the present moment and non-judgmentally. And the NICE guidance in England, which has recommended that mindfulness is to be used in treatment, talks about it as a way of paying attention to the present moment, using techniques like meditation, breathing, yoga. It helps us become more aware of our thoughts and feelings. So instead of being overwhelmed by them, we're better able to manage them. So if we think of our little person who's depressed, those layers of feeling blank, feeling sad, maybe feeling some self-loathing, that it's about being able to be more aware of what's going on internally, but not in a way that feels overwhelming. And there are many different forms of mindfulness, so sometimes it's kind of confusing if you read up on this because we use all these letters to describe them. So the original form was MBSR, which is mindfulness-based stress reduction. But when we're talking about depression, we're often talking about mindfulness-based cognitive therapy. So it's a kind of tighter program and a more focused program. And the word MBI is used to anything that's adapted. So a lot of what we do in the hospice would be mindfulness-based interventions that are adapted for our population. So it's always useful to think of that. But one thing I always say to people is, you can't be fully aware in the present all the time. We're like a wobbly man. We're connected to the present, we drift off, we come back, we drift off, we come back. So it's about being flexible. It's about learning to bend with and be with our experience and be with whatever life throws at us. So it's primarily about flexibility in that way. And in terms of the background to it, there's a lot of wisdom behind mindfulness, a lot of philosophy. So as we develop in the world, we're collectively developing our sense of self and our sense of the world. And one dominant view is that of man as valued by what he can do. So in the Western world, we value people too much by what they actually do. We're too inclined to say to people, what's your job? Where have you come from? What are you doing these days? What hobbies do you have? Whereas actually, we need to look much more at ourselves in our own being. And Francisco Varela is a very important writer in this area. And he says that the West does include a sense of self, but as a naive, subjective impulsivity. So in the Western world, when we think about ourselves, we're inclined to think about it in a naive, impulsive kind of way. So in other words, are you happy? What do you want? What do you want to eat? What do you desire? What course do you want to do in college? We tend to think of it too fast, too quick, without sufficient depth. So what mindfulness offers is a method to an embodied experience of your sense of self. So being able to be more uniquely who you are yourself, being able to have an internal balance around that, and a knowing of yourself. So in many ways, it's about unlearning bad habits rather than having to learn a lot of new things. So they talk a lot about removing obstacles. So I'll give you a very simple example of that. Over the years, I've learned, for example, that I'm quieter than I thought I was. I like to spend more time alone. I've discovered that drinking doesn't suit me at all. So I've had to learn to manage that much better. And it's coming from an inner knowing. It's not coming from an external voice in my head that says, don't go out and have a pint tonight. It's more a remembering how my body reacts to it, and a remembering that it actually doesn't suit me very well. So mindfulness invites us to get in touch with the real internal self that we are. Now, when we talk about evidence, and I'm going to get Professor Lucey to give us a bit of help on this as well, evidence is very important to those of us that work clinically and work in services, because it's about learning to distinguish what is scientific from what's folklore. And I'll give you an example around depression. In Irish folklore, robins were considered a cure for depression. So the heart of a robin was a cure for depression way back, probably way back before your grandmother's time. And the idea was that you cut it out and wore it on a little satchel around your neck, right? Now that's folklore, right? And obviously it's dropped out of Irish folklore over the years as well. We don't hear it very much at all. We're struggling to look at what's data from what people say, because I'm sure you've all heard people say, oh, I went to something and it was fabulous, it was fantastic. Now that's an assertion and it's an opinion. But data is where you really look at large numbers of people and you look at what benefits groups of people and what benefits people over time. It's kind of much quieter than somebody saying, I think it's fabulous. It's gathered slowly over time. We want to look at fads as distinct from best practice. So there is a feeling out there sometimes that mindfulness is a bit of a fad. And if you can bear with that and listen to where people are coming from around that, because we're going to try and prove to you tonight that it's not a fad, that there's a lot of weight and a lot of evidence behind it. And then, we've evidence from belief and from anecdotes and from personal opinions. And in my line of work, the kind of evidence that often comes up in that box is that as people head towards the last year of their lives, the evidence they're drawing on for how their death might be is often the death of their nearest and dearest. So they think back in their minds to, how did my mother die? How did my father die? What was it like for my grandfather? That's what they draw on. And sometimes that evidence is very frightening. And sometimes part of my job and the team's job is to help them think that their ending could be better, that they could make different choices, involve themselves with palliative care, talk more carefully to their doctors, that there's ways of managing things that might be different. And the last slide, we won't go through this in any detail, but this is how evidence is built in medicine and in science, that it goes from theory to trying things out, having modelling and exploratory trials, up to what's called randomised controlled trials. And then finally, the last stage is when it goes through a massive trial and it comes back into the hands of people like ourselves, and we use it clinically, and then we're interested not just does it work for a trial, but does it work in clinical practice over time? And this is a very important journey. And a randomised controlled trial, which we're going to show you the data from, is where if we had a large group of people here, we'd randomly assign one of you to mindfulness and one of you to treatment as usual. And so in the end, we're going to be looking at, did the mindfulness people do better than the people who simply had treatment as usual? And that's how you begin to tease out, is something actually really making a difference? And Jim, I might turn to you for a moment and just see anything you'd like to comment in that about evidence and how we try to manage it.
I think, Ursula, your point is really well made. And what we're looking for is something close to reality, something close to even the truth. And in search of truth, we're all hopeful travellers. This method that Ursula describes is the way in which people in a scientific world try to establish a truth. And it's open to test and retest. It's about evidence. And it's important that it's done objectively and fairly. And so there's constant questioning about these kinds of trials, constant skepticism indeed. And what happens is you get an amount of volume pointing us in a certain direction, and in truth people are very slow to take up the message from these. And that's probably rightly so. I think Ursula's made the point of how laborious and how painstaking it is to come up with scientific evidence. And that's something that's rigorous. There is a myth out there that this is a kind of mechanism that's only open to the large pharmaceutical firms who, in the days when medications were being developed, sadly very few of them are now, these could afford these trials. But actually, mindfulness is going through similar kinds of evidence-based, robust method that Ursula is describing. And that gives us more confidence that it is more than a fad or more than a folklore.
Yeah, and it gives people like Jim and myself the right to use it within a health service, because we can go to our managers and say there is evidence that this works. So that's the huge benefit to us of this kind of work. So how did it all begin? Everything in life begins with people, right? So in the World Congress of Cognitive Therapy, 3 men went to that conference, and 3 men got together in 1989, and they were the people who designed the MBCT, the mindfulness-based cognitive therapy program that most of us would use clinically. So Mark Williams, who is the chap over there in the white shirt, Mark Williams at that stage was studying the different types of personal memories that accompany depression. Because if you notice yourself, when your mood goes down, the personal memories that begin to arise are often sad memories, right? So I had a lovely gentleman who was in his 50s. He had minded his mother for 7 years. Over the course of those 7 years, he had stopped working. He was working as a plumber and he had stopped working. And what he found was, if his mood went down, he automatically started remembering the very sad moments in his mother's life. If he went into those memories, his mood got worse and worse, right? So he was on a loop of a very sad story about the end of her days that would just loop around in his mind all the time. So Mark Williams was studying that type of a shift that happened in people. Zindel Segal, who's in the centre there, was very interested in people's self-image, because what he found was that, again, people's self-image went down. So if people were depressed, they were more likely to perceive themselves as less worthy and less good. So my poor bereaved gentleman had not worked, had done a fabulous job of minding his mum, but his self-image was rock bottom. And one of his absolute convictions was that he would never work again. So a very important part of his recovery was him going through one of the employment programs, and he's back working now with autistic children, a completely different job. He's a caretaker in an autistic centre, and he loves it. And he's getting on terribly well. And that has been as significant as therapy in helping his mood come back up again, right? And the third person up there, John Teasdale. John Teasdale is a very, very deep thinker. And what John Teasdale had realised is we talk a lot about negative thinking in depression, and we know depressed people have very low mood. And we've gone after it in cognitive therapy to really encourage people to look at their negative thoughts, challenge their negative thoughts, rewrite their negative thoughts, which is hard work. And we know that if you can do that, it can help your mood. But what John Teasdale pointed out to us was, if you've that cycle going a lot of the time, negative thoughts, low mood, negative thoughts, low mood, they begin to interact. So what John was interested in was that when people's mood went down, the negative thinking got going. The two things were working together. So he was very interested in the fact that once you've had one episode of depression, very small things can set off another episode. So you're going along, you've had your therapy or your medication, you're feeling better in yourself, but small moments of sadness or small events in a life can then kick you back in. And you're left slightly bewildered, thinking, how could something that small set me back so badly? It's because it's tipping off this mechanism and it's setting it going again. Sadness and the thoughts are working with each other. So John Teaser was very interested in that. So the three of these got together and they concluded that the effectiveness of interventions to prevent relapse should be different from the ones in standard cognitive therapy. So we're going to stop challenging the negative thoughts. What they're going to do instead is increase your awareness of yourself. Awareness of when am I sad, awareness of when is this negative thinking going. Really support you by doing mindfulness and mindfulness exercises in recognizing that and standing back from it. But the third thing they got really interested in is increasing tolerance of low mood. So they had a theory which is that slowly over time you get worn down, you get tired emotionally, and your capacity to be a big pot in which to feel these feelings goes down. So that's what they began to target. And they designed, again, a very important protocol-driven therapy for depression, which they've published and is very, very available. Now, it was developed for people who are in remission, not currently depressed, but at risk for a depressive relapse or a recurrence. And most recent trials by Willem Kuyken in Exeter have suggested that it's most effective for people whose depressive symptoms fluctuate and who also report a life of early adversity. And that's been quite interesting for all of us to understand that as well. So you've had your first time treatment, you're outside, you're doing well, that's the time to do mindfulness, right? And that's the time to develop a practice that will sustain you and hopefully keep you well. So how do we know it might keep you well? I'm going to skip that one for a moment and bring you up towards the evidence. Right. So there's also a lot of neuropsychology in all of this work as well, which is terribly interesting. So they've, gone the route of putting monitors on people's brains, and they can show how the attention in your mind shifts when you do mindfulness and what different parts of your brain are activated. So here you go along to your mindfulness class and you start over on the other side there with your intention and your motivation, right? So we always ask of people, like Sinead was saying earlier on, can you be awake and can you be here? Can you be present to what we're doing? We ask people often to set an intention. So today I'm going to do my mindfulness practice. So maybe you can dedicate it to a person in your life you care about, or you're doing it because your goal is to support your practice. There's always that idea of gathering yourself and having an intention. And then you go up this side here and you do your focused attention and your practice and you involve your working memory. So you're going to focus on your breath and you're going to do your breathing, right? And the big thing that does is it gets you doing something other than ruminating, right? So it gets you to stop and focus on something else. And then you keep doing this, around and around and around you go, and the hope is you begin to slowly stabilize mentally. So your heart rate slows, your breathing deepens, you get steadier in yourself, right? And you focus on the object, which is your breath, and you steady, steady, steady around in that cycle, okay? And the purpose of it is to stop your mind going over into this big box here. You see mental proliferation? Okay? So it's to distract you from this other bit of your brain where you're there and you're thinking about the past, you're going into your episodic memory, which is your memory for past events, and your story about yourself, and you're going round and round and round on that. So the purpose of doing mindfulness is to stop you going there. It's to stop that going on in your head, giving your mind something else to do. And if you do it often enough, you begin to be able to decenter. So you come down this end, you're decentering here, it stops you responding, it gets your emotions more regulated, and the bit in the center gets much stronger. That executive monitoring gets steadier and steadier and steadier. So that's mechanically how it works, right? So what are we not doing? We're not looking for enlightenment, right? We're not going there. We're not going down that road. We're not looking to be different people. We're simply looking to stabilize our minds. That's what we're trying to do. So, general evidence, right? There is a lot of general evidence out there which shows that they've looked at studies that show changes in anxiety and in depressive symptoms in a wide range of psychiatric and medical disorders. And what Hoffman did was he looked at all the studies that reported changes in anxiety and depressive symptoms during the course of a mindfulness program. In some, our findings were encouraging and support the use of mindfulness-based interventions for anxiety and depression in clinical populations. This pattern of results suggests that mindfulness-based therapy may not be diagnosis-specific, but instead may address processes that occur in lots of disorders by changing a range of emotional and evaluative dimensions that underlie general aspects of well-being. That is a lot of words. But what is he actually saying is this is useful for a large range of problems that have anxiety and depression associated with them. So the Veterans Administration in America has done a massive study on the benefits of mindfulness because they now are recommending it they train soldiers before they go to war in mindfulness, and they use mindfulness when they come back as well. So they have a huge mindfulness program for the American soldiers that they've invested a lot of money in. So to read this chart, the weakest evidence is on the left-hand side. So fibromyalgia, for example, has had a number of trials and has not shown huge benefit. So be careful of that one. And then as you move across, you can see, stress, sleep, MS, cognitive function, a big pot there for cancer because there's been lots of studies on cancer patients. The better ones are up high. For cancer, distress is doing better. There's some good studies for substance abuse. There's studies around smoking, all of these kind of things. So I put this up because I want you to get a sense of the fact that's been a huge amount of work done on it, a lot of studies, and that people are very careful about watching where is it working, where is it beginning to work, where is it not working so well, and then finally these upper ones are where the best data is. For chronic illness, it's very good. For psychological distress, for MBSR, for depression, quite a big pot of work done on depression. So that gives us confidence that we can say to you, this is something that will be worth going to. Quite a lot of good work on pain, and then slowly there's work being done on psychosis. But the evidence is stronger the further up on that side that you go. So there's quite a large body of evidence for it. And in the one on depression, in that pot, there is 14 randomized controlled trials. In other words, 14 trials where people were looked at who had done the program compared to people who had had treatment as usual. So that's fairly robust evidence on that side. There's a lot of work done out of Exeter University, and Willem Kruiken is the person who has worked in Exeter, and he took all the evidence on what happens if you put people into a mindfulness program, and does it make a difference to their relapse rate. So the top line here shows you the people who didn't go into the mindfulness program had a 30% greater chance of relapsing, whereas the people who went into the mindfulness program maintained their recovery levels quite steadily, right? So the bottom line is the people who did the mindfulness program. Now, just a word of caution about this. The people in programs are people with unipolar depression. In other words, they only have depression and nothing else, right? Now, when Jim, Sinead and I work, it's rare enough we're working with people with only depression, right? We're often working with people with a muddle of things. So you get these very good results when you pick the people for your programs, right? Whereas in the real world, we have to go a little more cautiously, and we have to ask our patients what it's like for them, and we have to work with people probably in a slightly more cautious way. So what would I say the key points are from the evidence? That individual patient data is very good. It's based on large trials. One of them had 9 trials with 1,329 participants. So the data is good in terms of its numbers, and that patients receiving mindfulness-based cognitive therapy have a significantly reduced risk of a depressive episode when they're followed up for 60 weeks. There were 60-week follow-up compared with those who had treatment as usual. And then the last stage always is that stage of implementation. So where you look more generally at what are things like in practice, right? And in England, they've done a lot of work on this. So they've looked at mindfulness-based cognitive therapy, which is the one for depression, as a prevention program, and it's been developed from research with mechanisms to manage depression, relapse and recurrence, right? So that's the program we've been talking most about. That it is effective compared with usual care and maintenance on antidepressants. It is cost effective because, of course, a group program like this, on average, it means that a therapist is working 5 hours with each patient because it's a 20-hour program, but usually there are 8 people on it. It has evidence of a mechanism. In other words, people have thought through their theory. We now have published standards for teachers that we're all quite conscious of trying to reach it. So in order to teach, for example, I have to have a practice myself. So I have to sit on my cushion for 20 minutes a day. I have to go to 1 mindfulness retreat a year. So, you know, we have to keep ourselves steady so that we can lead people sitting and doing mindfulness. It is now recommended by the National Institute for Clinical Excellence in England as a psychological approach to preventing depression relapse among patients who've had 3 episodes of depression. So overall, it's been brought in a lot of English health services specifically for this group of patients. There is a lot of professionals now would have done some form of training because it is recognised as valuable. And as Jim was saying there, parts of mindfulness have been integrated into other therapies as well, because the value of being able to stabilise yourself is seen as useful across a whole range of therapies. There are now teacher training programs in England, the Netherlands, Australia, America, and Ireland now has its first Masters in Mindfulness, which is based in UCD. But it's still very much something we encourage people to practice a lot. It's not an academic training so much as a practitioner training. So that gives you an overview of where we're at, from theory to the big randomized controlled trials to now how we're trying to implement it. So I think I would certainly be happy to say it has an adequate evidence base. The best interventions are the 6 to 8 week ones that require some home practice and an experienced teacher. And the best use of it in depression is when somebody is in remission. So I think we'll pause at that point, and the last little bit I want to just say a few words about the future, because we were talking about the future before we began this. And the future is going to be different in many ways. We're looking at a very young generation that are probably more aware, they have less stigma, they're more willing to be very responsible. And so I picked Anne Wang as an example of this generation that's coming up, because I think she's very typical. She's, I think, 28 years of age. And at 22, she was an entrepreneur. She set up her own company, which is called Enro, and it's a company for weddings and funerals. She designs weddings and funerals, right? But she started by talking about the fact that she was so enthusiastic about this. They won the Forbes Under 30 award. They had finance coming from very big financiers. She said there was no time to sleep, no time to eat, no time to breathe. At our busiest, I was in the office from 7 a.m. to 2 a.m. In fact, I decided it would be simpler if I just moved into the office. I saved on rent, I had access to a shower, I slept behind my desk. It was a no-brainer plan. But after a few months, I hit a wall. I hit a total wall. I was constantly anxious. I couldn't make decisions. My confidence had deteriorated. My body was revolting. I felt my ambition had failed me. The spark that I thought was going to carry me forward seemed to have gone out. My problems were terrible. I felt I couldn't rest at any point in time. The problems were caused by the habits that I'd cultivated for success. The very things that had gotten me through college and gotten me successful were now working against me. I was experiencing serious depression and anxiety and was on the path to a complete mental and physical breakdown. But she's 30 and she's young, so what does she do? I signed myself into a yoga teacher training course. So she didn't go to see a psychiatrist. She didn't go to a hospital. She signed herself into a teacher training course. And over that year, it took her a year, she started nurturing her health and beginning to do her mindfulness, do her yoga, and manage herself much better. She said, in this journey, it wasn't just about reducing stress, it was about understanding my stressors and actually restoring my energy. We all need to make a mental shift and to realise that weakness is not a flaw, it's an understanding that something needs to be done to build our endurance. So I think that's what the future is going to be like. Lots more mindfulness, lots more yoga, lots more taking real responsibility for our lives. So I think the future is hopeful. Thank you all very much.
Thank you, Dr. Ursula Bates. Now, if you just tuned in, this is WIMS FM, live from St. Patrick's Mental Health Services. I'm Dr. Sinead Lynch, and I'm going to be moderating a chat now between Ursula and Professor Jim Lucey. And I really enjoyed what you said, Ursula, about mindfulness allowing us to be flexible, to just be with the human experience, whether it's good or bad. And I know you pointed out so much evidence, but maybe if we were to just strip it back, how do you, maybe in your own life or even as you describe to people, how does it allow us to just be? Because we don't often want to be with painful experiences.
I think it's about having a place to go within yourself. The value of learning to breathe slowly and deeply is that you slowly begin to be able to feel internally where your point of rest is. Like I know when I sit myself, initially I have a band of tension across my chest because I'm a bit wired normally anyway. And so it takes me a good 10 to 15 minutes to drop below that band of tension. And then what I simply have is an internal feeling of kind of, my body just begins to settle. And so that now becomes a marker within myself. So I can, during the day, begin to realise I've lost that internal state of rest. I begin to recognise that I'm walking too fast, talking too fast, I've booked too many things into my day. And it's not that I can necessarily get back to it, but I now have a gap where I realise, pause for a minute. And in the hospice, what we do a lot of the time is we stand for a moment outside a patient's door, feel our feet on the ground, and take a breath before we go in to see the patient. So it's about having these small, quite ordinary things that you do, but that you do over and over and over again. And I think that's certainly what helps me personally. And I think maybe to come back to your notion of change, I mean, life has changed dramatically over the course of all our lives, and change is increasing. So I think we need to have ways of managing change, you know.
Yes, and it took a yoga camp about 10 years ago for me to realise I wasn't even breathing properly. So I think some people find out in different ways and then they become less fearful of, oh, my breath actually helps me get in touch with myself. But it takes practice, doesn't it, Jim?
I think it does, and I think it is about a style of practice, a style of living. And there are some misunderstandings about what we're saying. We're saying that there is a way, and there are numbers of ways in which we can become at ease and more able to adapt or experience the real stresses of the world. Now, I don't know whether I'm at ease with the idea that this is a more stressful time than another stressful time. I just find it difficult. I think it's a more stressful time, but I don't know. I didn't live through the Second World War or through Attila the Hun or whatever. I think life has never been easy. I think life is hard. I think it's a good thing to recognise. And I think at times civilizations have been better at managing it, or could be better. Certainly at the moment, the social media age, the 24-hour news age is difficult. Even the Starbucks age with double espresso is difficult. You know, people are wired. Yes. And so I find it very difficult to watch 24-hour news. I'm constantly being told I'm going to be updated about the latest disaster. It's stressful. Especially since I can't do anything but express my own feeling of pain with that. Mindfulness isn't some loss of exposure or loss of identification with the world. In fact, it's a method to have far greater and more meaningful identification with the world, because what you're saying is, I'm going to take out of my response all the clutter, all the things that get in the way, all the things that stop me being able to be present and indeed identify with the events. And so I think it is a practice, and a route towards practice, which isn't new, of course, but perhaps is all the more timely because of the particular way we're living and the particular stressful life we have.
Mm-hmm. And Ursula, you spoke about how we live in a busy world, and how that, often the opposite of mindfulness can be kind of forgetfulness, or we keep going, or, you mentioned about being human beings, but we can often be human doings.
Yeah.
But in terms of how mindfulness allows us to maybe embrace the full spectrum of life with no judgment, do you find it difficult to bring in the no judgment part?
Yeah, which is a very central part, right? It's that notion of trying to get away from it's good, it's bad, I like this, I don't like that, and trying to keep in a slightly more neutral place around things. I think it's something we all struggle with. I do think I've noticed over time, with increased practice, I get less roused up by things. Do you know what I mean? I get less stirred up, which I think is very helpful. And I think then trying to I notice more now if I'm really desiring something, do you know what I mean? If I'm tightly locked onto something and trying to kind of ease back off it and not be so locked onto something.
Yes, it's like that pause you mentioned, like that breathing before you see a client or something. It's allowed you to just pause, so we don't go into that automatic response.
Yeah, that's yeah.
I think there's something worth saying, though, in addition to that we've already said about non-judgment, because I think people need to be, in a way, supported in that, because it seems radically different. No one is recommending here the acceptance of the unacceptable. It's not actually judgment about what's happening externally. It's principally non-judgmental about what's happening within us. And that's really the difference. In acceptance and commitment therapy, this is very clearly understood, so that one is asked not to accept the unacceptable, the traumas, the abuses, the terrible things that mankind, the savagery that we can do to each other. We're not non-judgmental about those at all. But what we're saying is that in full catastrophic reality, we're going to be non-judgmental about the way that makes us feel, so that we can move on. And that's I think that allows people get the idea of non-judgmental. I'm not blaming myself for the pain I feel. Indeed, I'm not going to actually let my pain get in the way of me attending to this reality by me being judgmental in advance of it. So that in your world, I presume, Ursula, no one is suggesting that death isn't final. Or that it isn't perhaps an avenue to something else. We're not judging anybody's view of death. But we are actually being non-judgmental about our experience of death. Isn't that the difference?
Yeah, I think we wouldn't in any way ever say that death isn't a personal trauma for people in many ways. I mean, it's facing into the unknown. So of course it's a very difficult experience, but it's about using these techniques as a way of moving towards it with greater calm or greater steadiness. What we noticed in the research that we did was that as people moved towards the end of their lives, they became a lot quieter, very naturally a lot quieter, which begs an understanding of silence, that silence is very important. Whereas I think from some other work, say Kubler-Ross's work or other work, there was this pressure to feel that people ought to be talking about their dying and adjusting to their dying and accepting their dying, a kind of pressure in that direction. Whereas mindfulness would suggest that no, in the depth of their being, people move much more gently at the end of their lives. And with one client, I remember asking her, how was her day? And she said, I'm coughing mindfully all today. Coughing is my practice today. And she had a very irritating condition, or a very irritating cough. And that was her practice for the day. And that's as honourable as anything else, you know.
I think it's also possibly about using the word maybe allowance. So yes, like we have this idea that acceptance is, I have to resign, but actually allowing something to just be, because we're powerless to it, like death.
Yeah.
Or it's the zones of influence versus the zones of concern. Isn't that one of the concepts out there? In other words, it is about being able to distinguish that which we can do and that which we cannot do anything about, and really have to recognize the difference honestly with a kind of integrity. In order to make any difference, we have to undo the confusion of our trauma, of our distress. And that dissolves with mindfulness, because you start into a point where you recognize which you can do and which you can't do.
Yeah, but actually, to pick you up on that, I think it's very important to have a period of finding your own story or knowing your own story. So that's why it's very important maybe at times to do some therapy before you do mindfulness, right? Because in order to stand back from something, you have to know it in some way, right? And I think particularly there's a whole generation in Ireland who have had great difficulty finding words for their story, right? Because they were silenced, and because in many ways there was no language sometimes to describe what their experience has been like. And I think we've gone through a very useful period of finding language and allowing people witness to what their lives had been like. And that's, we would never devalue that in any way.
I think that's right. I think one of the things that again is a misconstruction of mindfulness is the idea that it's in the moment and that's all there is.
And that's all, yeah.
Being in the moment isn't about a senseless notion. It would be senseless to think that we don't have a narrative to our lives. But in fact, we've been unable to access that narrative for want of a vocabulary, or indeed a sense of peace sufficient to be able to communicate it to each other. In a way, we've been shouting at each other or gagging each other, but not mindfuling each other so that we can talk. And once you get that mindful space, the hope is that you can open the narrative, tell your story. Certainly, it's funny, Ursula, how you moved from evidence in your talk, which is absolutely right, but like us all, you found a powerful personal story to illustrate it. And so we're in a world where the practice is personal. It involves stories. And I think one of the real things that's made humanity, not to be too grandiose, but humanity effective as a species is because we harness stories. We actually have tales to tell, and we gather around those tales. And that's why, indeed, whether you're religious or non-religious, a believer or non-believer, mindfulness can contribute to you in a way that allows you access the story. Non-judgmentally, in terms of not judging how you react to it as good or bad, but reacting it absolutely fully.
It's that common humanity, and maybe it sounds like you're saying reducing that inner critic when we're saying not judging.
Exactly. So, the inner critic is the one, I suppose, but it is about, for many of us who've taken years to come to mental health care, or years to telling our story, years to actually journeying through rather than around our pain, to ask somebody to just be in the moment is asking them to do something that's fatuous and silly. And intelligent people tell you that pretty quickly. And I find, I don't know whether this echoes experience in the hospice, that you can't show that much disrespect to people and expect them to work with you. So the narrative is wonderful.
I think that's very true, that we've always got to be careful about laying things as burdens on people, saying, well, you really should be doing this or you should be able to do that. Like in the hospice, really, we see ourselves as an environment. I mean, the purpose of coming to a hospice is to wrap an environment around somebody within which their dying can be held. So we would see the people giving the cup of tea are as much part of the team as somebody like myself. It's a wraparound environment. And then gradually what you want to support the person doing is taking some of that within. That's what you're talking about, Jim, really, is so that, and we use mindfulness as a technique to help them build a pot within themselves they can hold their own experience. And I think a hospital is like that. You put an environment, and then within that, slowly you hope that that something goes within, and it's simple things. It might be, a moment in the garden. It might be looking at some of the art on the walls. It isn't always what somebody says to you, or a moment being treated respectfully by somebody. They're the things that go within sometimes and hold on,
We really believe that as well, Ursula, and we talk about developing within a unit or a space within our service, developing the French word, a milieu, an environment where in fact recovery is of its being, everything in it. Absolutely, the tea and the wall coverings, the paintings, the access to garden are more than just items.
Yes,
but they're actually therapeutic tools and opportunities to be mindful in, or to use mindfulness to access something else that you're journeying towards. But it'd be important not to overstate the evidence. The evidence is that this is a help.
That's right.
And the evidence is that I think that this is part of a recovery in particular groups, people who have certain conditions that or certain symptoms. Certainly there's some good evidence for depression and anxiety. I don't think there's good evidence for bipolarity, for example.
Yes, exactly.
And that's important to know, and Aware needs to understand that. We're not talking about some kind of panacea at all. But I think it has made us humane, or hopefully has made us more humane. Except when we start saying, now you will be mindful. You know what I mean?
Go to class.
I think Kubler-Ross's work has been misunderstood. I don't think she ever meant it, but people did take from it that you had to go through the certain stages of death in a rigid order and tick them all off, otherwise you weren't actually doing the dying right.
Exactly.
And that's not really the way it is. It's the same with recovery, I think. I don't know whether you'd agree, Sinead. There isn't a right way to get well. But there is a way to be well, and that's your own narrative, and I think helpfully your own mindful narrative.
And even as Kubler-Ross wanted people to just talk, I mean, our talk is always going to change. You mentioned earlier about society now, and it's different again. So we're going to have a different narrative again, and maybe it's about just allowing that voice and that change. And I think with mindfulness, it's maybe, you talked about some of the myths there, and it's not just a tumbleweed. It's not a nothingness, in the mind, and it's
no, it's not emptiness.
No.
Yeah.
It's not some kind of narcissistic or boring or isolative escape. This is actually a route to real engagement with the issue, whether it's the dying or whatever else. You mentioned change there. You mentioned change, Ursula, as well. We had an interesting talk from a Scottish psychiatrist last Founders' Day here about the tremendous campaign the Scottish have had to introduce reform of their drink licensing laws and minimum pricing. And so the whole world is looking at this. Ireland is being very slow to take up their initiative, sadly. But we all hope that it helps the Scottish. But he was talking about change, and he said, don't believe anyone who tells you, plus ça change, plus the même chose. Actually, things do really change. And we don't attend to this. They really do change. So I was put to the mind to try and figure this out. And I was talking to a group this morning at the mental health lecture we had this morning in terms of World Mental Health Day. This is World Mental Health Day. And I was remembering my own childhood experience of being in a children's hospital, just as an example. So I was in a children's hospital quite a bit, Temple Street. And in those days, you were put in bed and you couldn't get out of the bed as a child. You weren't allowed to get out of the bed. And if necessary, as in my case, your hands were tied. My hands were actually strapped up. That's extraordinary. Just funny how it occurs to me. Many years later, I was a junior doctor and later on, a more senior doctor, working in Temple Street. There was no children in a bed. The children were either at home or running around. Some very, very sick children were in an intensive care unit, a thing that didn't exist in the 50s when I was there, or the early 60s. Everything had changed, and no one had noticed the change. But it was a real change. Now the children were running around and playing. And everything will continue to change. And many of the changes will be for the better. And that's not a judgmental thing.
No, but it's noticing, as you just said.
It's noticing the hope of that positively and acknowledging that non-judgmentally.
Yeah, and I mean, I think, there again, you talked about, we went from the science maybe to the heart, we'll call it.
But
Yeah, and I mean, I think just even knowing that we can just be mindful just by, we mentioned tea, about how important it is in the hospice setting, in the hospital setting.
Yes.
But like, isn't it wonderful to just be mindful over a cup of tea or coffee? Just take time.
Everyday activities are very important,
And so maybe in a way, it's not that we're simplifying mindfulness, because it takes time, it takes practice, like lots of things. But maybe we can start out by talking about some of the things that we're just mindful about, that we take, the joy in. Again, I'm not judging my cup of coffee, but I am actually, if it's bad. But the thing is, it's just maybe saying, I'm going to sit with this, I'm going to enjoy this. I mean, do you feel like you both do that on a daily basis?
I wish. What are you, Ursula?
Well, I suppose I work hard at it because I use it so much. But I suppose in a way I was thinking tonight about endings and ways, how we're going to end. I was just thinking, I just want to just let you know that, today, for example, in Blackrock Hospice, I sat for half an hour with 4 gentlemen and 2 ladies who are very, very seriously ill, in a little group for half an hour, just sitting, breathing, and appreciating the garden around us. And that's the work. That's why I do the work, and that's why I want to do the work, if you know what I mean. That it gives me a way of being with people that's not intrusive. I'm not asking them how they feel. I'm not, we read poetry together, and these are gentlemen who would have left school at 15, and we sit and read poems. And it's a nice way to be.
And it sounds like it's finding joy in that present moment.
Finding joy in the moment, and gratitude in the moment.
And hope. I think hope is essential.
And knowing that if it's bad, that all things pass as well.
That's okay.
That's okay. Thank you both. It was wonderful to listen to you both, Dr. Ursula Bates, Professor Jim Lucey. Our WIMS FM listeners will be tuning out now, so thank you for listening. A podcast of this event will be available on walkinmyshoes.ie tomorrow. And the next event in the WIMS FM live series is Life Online, the implications, good, bad, and the ugly for our mental health, featuring Dr. Coleman Noctor, and that's tomorrow evening at 7. So from myself and the panel, thank you for listening.
Thank you, Sinead. Thank you very much. Thank you, everyone.
Thank you.